Okay, greetings everyone. This is Dr. Mohammad Mohsin. I am the pediatric electrophysiologist and currently affiliated with National Institute of Cardiovascular Diseases. Today, I am going to talk about cardiac arrhythmias in pediatric intensive care unit. I have nothing to disclose regarding these presentations. And before starting my presentation, I wanted to make sure that all participants who is going to attend this presentation should have the basic understanding of ECGs and rhythm disorders. I am not going to talk about the basic ECG reading and the common arrhythmias, and I am going to talk about a bit more on the concepts and some common arrhythmias. So, arrhythmias in pediatric intensive care unit, when we talk about arrhythmias, it's a common problem in the pediatric intensive care unit, and the pediatric intensivists have to deal it almost every day. And the more likely patients have structural heart disease like hypertrophic cardiomyopathy or LV dysfunction when they are going to have rhythm disorders. But this is not the necessity that patient have the structural heart disease. The reason of having these arrhythmias could be anything like hypoxia, ischemia, catecholamines, electrolyte imbalance, or central lines. So as an electrophysiologist, when we deal about, when we look at any arrhythmia, we start thinking about how to treat it. But before that, we also think about why some patients have arrhythmia, why does not have all the patients have arrhythmia, and why specifically some patients have arrhythmia. There could be any of those reasons that can put the patient on risk of developing abnormal heart rhythms. So the physiology of the arrhythmia or the reason of having the hemodynamic instability is totally dependent on the ventricular response because of those arrhythmias, their duration, how long the arrhythmia does happen, and what was the cardiac functions look like of that specific patients. Like if we're talking about a patient who has EF of 15 or 20%, any kind of SVT means supraventricular tachycardia with a heart rate of more than 200 could be could put that patient into hemodynamic instability. But for a normal heart, normal cardiac functions, these SVTs does not cause any hemodynamic instability most of the times. So when we going to manage the patients with arrhythmia, the patient underlying cardiac status is the key to management, and we should know about it. So when we talk about the bradyarrhythmias, means low heart rate, what it can do? It can decrease the cardiac output with the fixed stroke volume, and that can cause the hemodynamic instability. Similarly, tachyarrhythmias can cause diastolic, impaired diastolic filling. It can reduce the cardiac output, and it can result into the hypotension. Similarly, if patients have tachyarrhythmia that is going on for many days, it can cause cardiac dysfunction, and it's not a uncommon problem that patients presented with tachycardia-induced cardiomyopathy, and most of the times those patients are being treated as myocarditis or dilated cardiomyopathy, but the etiology is tachyarrhythmias. So how should we approach arrhythmias in pediatric intensive care unit? So when we deal with some kind of arrhythmia, so there are certain things that needs to be ruled out. And number one thing are the artifacts. The other problems that can cause problem are mechanical problems due to central lines or electrolyte imbalance, like potassium, like calcium, and magnesium. They should be thought in all the patients who have some kind of arrhythmia in PICU. I will give some examples, like in this picture, this patient having a very frequent premature atrial contractions, which we call PSCs, and he was on many medications, including beta blocker. But when we look at the etiology of those PSEs, we come to know that on the X-ray he has a very deep CV line place, and that's irritating the myocardium and causes the PSEs. So the medication will not help. You have to pull that line out of the heart into the SVC. Similarly, when we look at this ECG, you can be confused it with the ventricular tachycardia, because this is very ugly looking ECG. But when you look at the patient, he is eating well, he is okay, he is admitting from some other reasons for monitoring, and there is no reason or hemodynamically instability that can give you a clue that patient is into the ventricular tachycardia. So these are the artifacts because of some mechanical vibrations that was happening near the patient, and it can cause these artifacts. So you need to be careful about it. Similarly, when you look at these kind of ECG in which you can see very bizarre QRS morphology, the first thing you need to know what is the heart rate in this ECG, and you look at this, the heart rate was around 120 beats per minute, which is not very slow nor very fast, but the QRS morphology look very bizarre. So you look at this ECG and you come to know that this is a very typical ECG in which you can see the sine waves, and it can make you think of the hyperkalemia. So you have to treat the hyperkalemia rather than treating any kind of arrhythmia with antiarrhythmic medication. So these things need to be careful about when you are in ICU. So when you go into the you have some patient with rhythm disorder or some rhythm disturbance, the first question that need to be asked is either patient is stable or unstable. If he is unstable, then you have to go like cardiac arrest or pulse algorithm and go according to it. I am not going into the detail of it. You all, I believe all of you have the pulse certification. So for unstable patient, you have to immediately start CPR if there is any ventricular fibrillation or asystole going on, and treat accordingly, cardiovert or give the shock until you deal with the unstable arrhythmia. If the patient is stable, do not jump into treating the arrhythmia, rather than try to know the etiology, and then according to the etiology make your plan to treat those kind of arrhythmias. So a prerequisite for diagnosing those patients is a 12-lead ECG that should be attempted, and or rhythm, at least a rhythm strip should be printed. There is no alternate of 12-lead ECG for an electrophysiologist, for a cardiologist, and there should not be any excuse or explanation trying to say that oh, patient was not able to get the ECG. Yes, if patient is unstable, obviously you could not get the ECG. But if the patient is stable, you should get a 12-lead ECG. So just for general consideration and information and the background knowledge, you need to understand that there are certain atrial arrhythmias like PSEs, or we can call it atrial ectopics, supraventricular tachycardias, first degree heart block, atrial flutter with 2:1 conduction, or occasional PVCs. They are usually stable rhythms, and they does not cause hemodynamic instability, but need close monitoring before developing some unstable condition. So you need close monitoring, but usually they are stable rhythms. In general, ventricular arrhythmias like VT, like ventricular fibrillation, are potentially unstable rhythms. And there are many different treatment modalities for those unstable rhythms like cardioversion, defibrillation, or pacing in case patient have a asystole or low heart rate bradycardia. At this point, I also try to mention you guys that when we look at the tachyarrhythmias, they are how the pediatric, not necessarily the pediatric, how electrophysiologists think about those arrhythmias, especially for the tachyarrhythmias. So when we talk about tachyarrhythmias, there are usually two mechanisms that can cause those tachyarrhythmias. One is the automaticity. By automaticity, we mean there are some cells in the myocardium which get excited and start depolarization that is faster than the sinus node. So let's suppose there are some cells in the left atrium that get excited because of any reason, and it start firing at a rate that was faster than the sinus node. So those patients start having some kind of a SVT, but the mechanism of that SVT will be automatic tachycardia, not the other kind of tachycardia, that is reentrant tachycardia. For the reentrant tachycardias, usually there are two different circuits present that are connected proximally and distally, and there are some other prerequisite. And to understand that, you should assume, or you should make an assumption that any electrical impulse go into that circuit and goes around and around. That can cause the reentrant tachycardias. There are certain characteristics that can help in differentiating reentrant from automatic tachycardias. Like usually reentrant tachycardias are very sudden onset and sudden offset. So they are usually a single beat onset. Once it started, it continues at a very fixed rate and then suddenly stop. When you look at this kind of arrhythmia, you start thinking of some reentrant tachycardias. As opposed, if you see a tachycardia that is going at like 200 beats per minute, it's changing its rate. It sometimes goes like 220, sometimes goes like 180, and at the same time it comes in like burst pattern, comes and goes. It gives you impression of automatic tachycardia. Why it's important to differentiate between automatic and reentrant tachycardias? Because the treatments are usually different. And one most important characteristic is automatic tachycardias are usually not respond to cardioversion, electrical cardioversion. For example, if we think of junctional ectopic tachycardia, which we see quite often in the cardiac intensive care unit, those are usually automatic tachycardias. And if you try to convert those, cardiovert those arrhythmias or jet rhythm, it will not work. So for the cardioversion to work, there should be a reentrant tachycardias. Atrial fibrillation and VFib are exception, in which our concept is there are some microcircuits. That's why the cardioversion work in AFib and VFib as well. But for other automatic tachycardias like ectopic atrial tachycardias, cardioversion will not work, and those patients has to be treated differently. So again, I will go back to our presentation. If the patient lose consciousness or become hemodynamically unstable in the presence of tachyarrhythmia, you immediately go for the electrical cardioversion. And if it does not work, then you can think of other reasons. Similarly, if the patient lost consciousness or become hemodynamically unstable, and on the ECG you find a bradyarrhythmia or complete heart block, prompt medical therapy in the form of atropine, epinephrine, or risupril, or cardiac pacing, external or internal, is indicated. By the time you arrange the external, like internal temporary pacemaker, external cardiac pacing using the transcutaneous pads can be achieved. And in case you are in a setting where nothing is available, you should immediately start CPR. So now, after getting those basic ideas, I will go quickly into some abnormal heart rhythms that most likely you are going to encounter in your daily practice. So first, I will go into the bradyarrhythmia. So when we think about the bradyarrhythmia, you should go back to your basic of cardiac pacing and start thinking that usually SA node is the pacemaker of cells and it fires at age-specific rates. So if the patient is developing bradyarrhythmia, there could be any two reasons. The first reason could be the SA node is not firing at appropriate rate. It's firing slow. So for me, in a normal heart rate is 80 beats per minute. But if my SA node is sick because of any reason, it start firing at a very small, slow rate, like 40 beats per minute or 30 beats per minute. And then I will develop bradycardia. So for sinus node dysfunction, you come to know that so when we talk about the bradyarrhythmias, so the first thing is failure of impulse generation, like I already told you, like SA node dysfunction is the failure of pulse generation. So in that case, there is a failure of SA node automaticity, and as a consequence of it, someone can get bradycardia. And if because of this bradycardia patient gets symptomatic, we will call it sick sinus syndrome. There will be P waves before every QRS, like in this ECG. I will point out the P waves before every QRS. When we look at all the QRS, there is a P waves, but P waves is firing at a slow rate as compared to the age appropriate rate. So this is because of the sinus node dysfunction. Similarly, the other common cause of the bradycardia is the sinus bradycardia, and again the sinus bradycardia is the rhythm in which the SA node is firing, but firing at a slow rate that is low for the age. And when we look at the sinus bradycardia, we tend to know the cause, and there could be many causes like oversedation, like hypothermia, increased vagal tone, hypothyroidism. So look for those causes and try to treat those causes. Otherwise, there is no need to treat bradycardia itself. Yes, if the patient is unstable, then you need to pace him. But if a patient is asymptomatic, there is no indication for treating bradycardia. You should look for the cause and try to treat the cause. So this is again an ECG of sinus node dysfunction for a 5-year-old child, in which the heart rate is pretty slow. When you look closely in all the QRS, there is always a P wave before QRS, and you could not find any P wave after which there is no QRS. Means there is no heart block. This is only sinus node dysfunction. And when we look at the guidelines, I will read only the class 3 indication. So permanent pacemaker implantation is not indicated in patient with asymptomatic sinus node dysfunction, right? So if the patient is having like heart rate of 40 or 50, but he's asymptomatic, there is no need to treat the bradycardia. You can ignore it till the time the patient is stable. Yes, if the patient become hypotensive, then in that case you need to treat those bradycardia. The other reason of having the bradycardia is failure of impulse propagation. The failure of impulse propagation means the sinus node is working fine, it's firing, and how we come to know that it's working fine, there will be P waves formed because of atrial depolarization normally, but there is a problem in the AV node, and the impulse that generated from the SA node depolarize the atrium is unable to conduct to the ventricle, either unable to conduct or slowly conduct. So failure of impulse to conduct normally to the ventricle is called heart block or AV block. This is always the problem of the AV node or His-Purkinje system. There are different kinds of a heart block. So first we start with the first degree heart block. In the first degree heart block, there is always a conducted P waves, but very slowly. So there is a prolonged PR interval on those ECGs. So if you look at the first ECG, there is a P wave and it's forming the QRS every time there is a P wave, there is a QRS. But the PR is not normal, it's very prolonged, more than 200 milliseconds. So this is called the first degree heart block. The PR is prolonged. While in the second degree heart block, the conduction to the ventricle is intermittent. Some P waves will conduct to the ventricle, whilst others will not. So if you look at the second and third strip, in the first strip there is PR, for the second beat the PR get prolonged, and the third beats get more prolonged, and then you will find a P wave after which there is no QRS. So when we say there is a hard block, there should be some P waves after which you could not find any QRS complexes. So again, second degree AV block, Movitz type 2, the PR is fixed, but suddenly there is a P wave after which there is no QRS complex. So this is a second degree heart block. Similarly, when we look at the third degree heart block, there is a complete dissociation between the P and QRS. That means there are no P waves that can conduct to the ventricle, and there is complete dissociation. So in this last strip, you can see there are P waves with the very different PR intervals, and there are many P waves after which you could not find any QRS. And there is no relation between P and QRS. The PR is changing from beat to beat. So this is complete heart block. In the presence of complete heart block, any of escape pacemaker take over the responsibility, like AV node, like Purkinje fibers or ventricular myocardium, to prevent the asystole, and you can find any escape rhythm. So symptomatic bradycardia because of AV block or sinus node dysfunction can be responsive to atropine, isopril, or epinephrine until temporary pacing is available. If the patient gets syncope, you should immediately start CPR. And once the pacemaker is implanted, you can pace those patients, and you can see the pacing spikes in this ECG, and after their pacing spike, there is always a QRS formed. So this is a single chamber pacemaker that is pacing appropriately at certain rate. So now we will go into the tachyarrhythmias. So there are different kind of tachyarrhythmias. The two basic concepts I already told you. Whenever we look into the tachyarrhythmia in future, we will question ourselves that either it is an automatic tachycardia or it is a reentrant tachycardia, and then plan accordingly. So the number one reason of having the tachycardia in peds ICU is the sinus tachycardia. And when we try to describe the sinus tachycardia, this means a rate above the upper limit for normal for age. I can differ from this definition, and for your understanding, I will give you a simple formula to estimate what could be the upper limit of normal heart rate for any individual. And usually it's 220 minus age in years. So let's suppose if someone is 50 years old, his maximum heart rate could be 220 minus 50. That means 170 can be the normal heart rate if that patient is doing some exertion like exercise. So again, in the ICU, when you look at the sinus tachycardia, you have to rule out the causes of the sinus tachycardia like fever, infection, dehydration, and try to treat those causes rather than treating the tachycardia. So you are not going to give amiodarone or beta blocker to these patients. Instead, you try to settle the fever, or if the patient is anemic, try to transfuse him. If the tachycardia is persistent despite ruling out all those causes, then you can think of the hyperthyroidism, especially in the neonates, or because of some medications, like for some newborns, patients goes into tachycardia because mothers were on theophylline or some stimulants. Otherwise, many of times you will get this ECG in which you will see this pattern. I will try to explain this pattern and want every participant to describe this ECG in the similar manner. So first of all, I want to know what is the heart rate of this patient. So in this ECG, the heart rate of patient is around 240 or 250 beats per minute. So then I wanted to know what is the age of the patient. Let's assume the patient is 5 years old. And I will put the formula in 220 minus 5. So 215 could be the normal heart rate, maximum heart rate for that patient. But this ECG shows the heart rate of 250 beats per minute. That itself is abnormal. So in this ECG, only the heart rate will tell you this is some kind of a narrow complex tachycardia. So I am saying it narrow complex because the QRS complexes looks narrow. So when I try to explain this ECG or try to tell someone on the phone what I am seeing that he could not see, I will tell this ECG is the patient is having narrow complex regular tachycardia or regular narrow complex tachycardia at the rate of 250 beats per minute. So whenever you are going to see regular narrow complex tachycardia, that will tell you that is a SVT. So paroxysmal SVT, those are those SVTs that come in episodes. They are usually rapid, fast. They are usually regular tachyarrhythmias at the rate of 230 to 300 beats per minute, usually characterized by abrupt onset and termination. They have narrow QRS complexes. They are regular R2R interval, and most of the times it's very difficult to see the P waves, but it's not a prerequisite. There could be SVTs in which you can see the P waves are present, but still they can be SVTs. So when you look at these ECGs, they are usually SVTs. And when we are trying to give the definition of this paroxysmal SVT, we say they are usually abrupt onset and termination, because most of the paroxysmal SVTs are re-entrant tachycardias, but not all of the paroxysmal SVTs are re-entrant tachycardias. So it could be, it is not necessary that they are abrupt onset and offset. If it is, then you start thinking of the re-entrant kind of a SVT. Otherwise, it could be a automatic kind of SVT. So why it's important to diagnose those SVTs? Because in the newborns, especially in the fetuses, they can cause the congestive heart failure if left untreated. And even intermittent tachycardia at a slow rate that goes for days and weeks can cause ventricular dysfunction, especially left ventricular dysfunction. So there are some kind of SVTs that goes at rate of 150, 160 beats per minute. Usually they have the visible P waves, and most of the time they are disregarded as sinus tachycardia, and if they goes on and on for a few weeks, they can cause severe dysfunction. So this is a very busy slide, and this is how we as electrophysiologists think about the narrow complex tachycardias. But as a fellow, cardiac intensive care fellows, why I showed this ECG. So once you get this slide, so once you get the ECG of a tachycardia, and it shows the regular narrow complex tachycardia. So even before going into the regular narrow complex tachycardia, the impression of having the regular or irregular is important, because if some patient has irregular narrow complex tachycardia, you can see in this diagram, you can rule out like 10 different diagnoses only on the basis of regularity or irregularity. Similarly, if the patient has irregular narrow complex tachycardia, it could not be atrial fibrillation. So you rule out immediately only on the basis of regularity or irregularity. So first you have to describe it's a narrow complex or wide complex. Is it a tachycardia or not? So narrow complex tachycardia, then you tell regular narrow complex tachycardia. So for the ECG we saw before, we already solved this puzzle that this is a regular narrow complex tachycardia, and we already make exclusion of 5 different diagnoses, but there are like 10 different diagnoses are still on the board. So the next step you need to be make is try to find the P waves, and once you find the P waves, you can make the diagnosis of it's either it's a short RP tachycardia, it's a long RP tachycardia. There are more A's than B's. So I think all of this is beyond the scope of this presentation, but finding the P waves is also important. And when we say SVT does not have P waves present, this is not a correct statement. In SVT, it is difficult to see a P waves. That is a correct statement. So there are many kinds of SVT, and the treatment and the long-term follow-up and long-term prognosis are dependent on these diagnoses. And for these diagnoses, you have to tell they have a narrow complex tachycardia, they are regular, they are more P's or than V's, They are equal P's and equal V's or whatever, and then you can make the diagnosis. So similarly, one kind of SVT is atrial flutter as well. So in atrial flutter, usually they are also regular, but they can be irregular. They are rapid with a rate of 240 or 300 beats per minute. The ventricular rate could be regular or irregular, especially in units when 2:1 conduction is happening. Usually those patients present with the heart rate of 160, with the flutter rate of like 300 or 220 beats per minute, they are conducting 2:1. So the next step in diagnosis those kind of tachyarrhythmias is what I am going to tell you. So it's almost impossible looking at this ECG that this patient has the atrial flutter. So what you will do? You will give the adenosine, and what the adenosine will do is block the AV node briefly for 6 to 7 seconds. And once you block the AV node, then you can see the flutter waves going behind the QRS complexes. So by telling this example, I'm trying to make sure that adenosine is not only used for the treatment of many of those SVTs, but also is being used for the diagnosis. So whenever you give the adenosine, it's important to give it properly, but at the same time, it's equally important to print the ECG or rhythm strip when the patient is having AV block. So you can make some diagnosis, like in this ECG, the ventricular rate gets slows, but you diagnose atrial flutter. Once the adenosine effect is gone, then this patient again will be tachycardic, and then you start thinking, how will you treat the atrial flutter, either by medication or by cardioversion. So printing the rhythm strip is equally important, and adenosine does help in making the diagnosis as well. So how do we treat most of those SVTs? So SVTs in neonates and also in the pediatric patients, there are 3 phases of treatment. First is the termination, the second is initial therapy, and then the maintenance therapy. So how do we treat those, how will we terminate those SVT episodes? So for the termination, we use the vagal stimulation, like putting the ice on the face or blowing the syringe or give the balloon to the patient. So all those SVTs that are reentrant tachycardias, and the reentry does involve the AV node, like AVNRT, like AVRT, because of the WPW syndrome. These vagal stimulation does block the AV node briefly and does terminate the reentrant circuit. So it does terminate the SVT as well. So similarly, adenosine does block the AV node briefly, and it can also terminate the SVTs, but not all SVTs. That is important. So adenosine and vagal stimulation can terminate the reentrant kind of SVTs. But if the patient have ectopic atrial tachycardia, that is a kind of a automatic SVT, the adenosine briefly suppress the AV node, the ventricular rate gets slows, but when the adenosine get metabolized after 7 or 8 seconds, the ventricular rate again goes fast. So in that case, adenosine does have a diagnostic utility, but not the therapeutic utility. Similarly, if a patient is having automatic kind of a SVT and you are trying to cardiovert them, it is not going to work. So in the ectopic atrial tachycardia or junctional ectopic tachycardia, those are automatic rhythms. Cardioversion does not help in those rhythms. You have to use some medications to suppress those automatic focus. Otherwise, by using adenosine, either if you give it 10 times or 15 times, the ventricular rate briefly will get slow, but again, once the effect is gone from the system, the ventricular rate again get fast. So for those arrhythmias, you have to act differently and use some medications that can be used in automatic kind of arrhythmias or automatic kind of SVTs. So temporary pacing is again a bit of a specialized thing that can be helped in terminating many kind of supraventricular tachycardias. So how should a adenosine be given? And there is a problem I noticed while I'm practicing, because many of times I got the call or message that we give the adenosine and it doesn't work. So the main reason that it does not work was you or whoever administer the adenosine does not administer it properly. So how should we administer adenosine? There should be a rapid intravenous bolus. It either terminate the tachycardia or transiently block the AV node, and there will be slow ventricular rate briefly, but the ventricular rate get fast after 6 to 10 seconds. So therefore, a ECG strip should always be recorded when giving the adenosine. Like in this ECG, on the left side of the screen, we can see there is a regular narrow complex tachycardia is going on, and you give the adenosine, and when it does work, you see the tachycardia terminates suddenly, and then there is a restoration of sinus rhythm. So in this case, adenosine not only treat the SVT but also give you the diagnosis that this is a kind of a SVT that does involve the AV node and is a re-entrant kind of a SVT, because it does terminate with the adenosine. But at times you get this kind of a rhythm strip or ECG strip, in which on the left side you again see a narrow complex tachycardia that is regular, and you administer the adenosine. And once the adenosine is administered, there is a slow in the ventricular rate, there is a like pauses long, but on the background, if you look at my pointer, there are continuously P waves going on at the similar rate at which those SVT was going on. So that means these P waves are because of some ectopic focus that is continuing firing despite blocking the AV node. And this does not have to do anything with the AV node. So this is an automatic kind of a SVT that does not break with the adenosine, and you have to act differently. So generally for supraventricular tachycardia, you do for the termination, you do vagal maneuvers. Different vagal maneuvers can be used, but be careful using the carotid massage in the pediatric population because it has a high incidence of adverse outcomes. You can do icing on the face or like blowing the syringe. I already told you adenosine can be given, and if it's a re-entrant kind of arrhythmia, if it's a flutter or SVT involving the AV node, you can DC cardiovert. DC cardioversion does work in the atrial fibrillation as well, but if it's a ectopic atrial tachycardia or junctional ectopic tachycardia, adenosine and DC cardioversion will not help, and then you have to think about the other options. Usually those automatic tachycardias does respond to beta blocker. Almost all antiarrhythmics can work in those automatic tachycardias as well, but you should have some experience of using it. And for the maintenance therapy, any of those medication can be used. This is again a busy slide, and I want you to see for those. This is actually a PAS algorithm which should be followed. And when you look at those tachycardias, there is an importance of the QRS derivation, because that will tell you is you are dealing with the SVT or ventricular tachycardia. If the QRS are wide, most likely it's a ventricular tachycardia. If it's narrow, it's most likely a SVT or supraventricular tachycardia. These are general rules that for general pediatricians and those who are not specialized in electrophysiology or cardiology, for them, every wide QRS tachycardia or wide complex tachycardia should be VT until proven otherwise. So here is an example. So there is a neonate who had a surgery, and you are concerned that this patient has wide complex tachycardia. But when you're closely looking at this, there's a P wave before every QRS, and This wideness of the QRS because of the bundle branch block, because this patient had a history of some kind of a surgery, and during cardiac surgeries, most of those patients come with any kind of a bundle branch block. So that's the importance of having a baseline ECG or some old ECG with which we can compare the QRS morphology with the current ECG. So if we does not have any old ECG available or history available, then we could be suspicious that this is a wide complex tachycardia. But if we know that this patient has the same QRS morphology during sinus rhythm, then we are pretty sure that it's a sinus tachycardia. So similarly, if you look at this ECG, so again, I try to look at the heart rate. What is the heart rate? The heart rate is around somewhere like 200 beats per minute. It's a regular rhythm and it's a wide complex rhythm. So having a wide complex regular tachycardia is VT until proven otherwise. When you look at the rhythm spread lead to, if you look closely here in the ST segment, it's changing from beat to beat, and there could be some underlying P waves which you can find, but that need a lot of expertise and experience. So this is a wide complex tachycardia, regular wide complex tachycardia. So the next message is many of SVTs during the tachycardia could be wide. For that reason, when we look at the pulse algorithm for regular wide complex tachycardia, we can still use adenosine. There is no harm in using adenosine in regular wide complex tachycardia if the patient is unstable. So if the patient is unstable, cardioversion. If the patient is stable and there is no reason of having the ventricular tachycardia, the patient is well, the cardiac functions are normal, there's no suspicion of myocarditis or cardiac injury, the electrolytes are normal, and you are questioning why someone has a wide complex tachycardia, that is VT. So, but you look at this ECG, it says it's regular wide complex tachycardia. Still, it could be SVT, and as the patient is stable, I can still use the adenosine in that patient. And if it's a SVT, it will terminate the tachycardia. If it's a VT, it will not help. But I want all of you to remember this ECG. If the ECG show wide complex irregular tachycardia, you are not going to use adenosine. It can kill the patient because this irregular wide complex tachycardia is the pre-excited AFib. Pre-excited AFib means some patient with the WPW who develop AFib, their rhythm looks like this, irregular wide complex tachycardia. And in that situation, if we give you adenosine, it will block the AV node, it increase the conduction through the pathway and can put patient into the ventricular fibrillation. So irregular wide complex tachycardia, never use adenosine, cardiovert this patient and get rid of this rhythm. So when we look at some irregular heart rhythms, so before going into the irregular heart rhythms, whenever you see some ventricular tachycardia or wide complex tachycardia during your training or your practice, wherever you are practicing, always ask why. Why I does not have a VT episode or ventricular fibrillation episode, and why does this patient does have VT or wide complex tachycardia or ventricular fibrillation? Because knowing the etiology is very important. In children, you would not find ischemic heart disease, that is the number one substrate or etiology for ventricular tachycardias in adult patients. So there is no ischemic heart disease. So whenever I look any ECG of ventricular tachycardia or ventricular fibrillation, I always ask for a troponin level, cardiac imaging, getting the echo done, want to know the electrolytes, and any other thing that can put the patient under the ventricular tachycardia. Now, the last portion of this presentation are some irregular heart rhythms. Most of the times, those irregular heart rhythms are premature atrial contractions or premature ventricular contractions, PACs or PVCs. So I want you all to understand the meaning of these three words: premature atrial contraction. So when you look at this ECG, there are QRS that are going to, like, they are coming at the regular intervals, and there is some beat that comes prematurely. So this is the necessity. So if this beat, if there was a large pause and then some extra beat comes, then it would be a pause, not a premature beat. And this pause is because of the premature beat. So first thing, it should be premature. It has to come like here, but it's come prematurely. And then we have to decide it's either an atrial contraction or ventricular contraction. Because it's the same morphology of the remaining QRS, it's a PAC, premature atrial contraction. While in this ECG, again, the QRS are forming at regular intervals, but there is a premature beat that comes early. So one prerequisite of the PVC is fulfilled, like it's a premature. It's not resembling the other QRS, so that means it's not coming from the atrium, it's coming from the ventricle. That's why having the different morphology. So it's a premature ventricular contractions that are coming pretty frequently in this ECG. So whenever you see those irregular rhythms, you should think of those PACs and PVCs. If it's same morphology of other QRS as PAC, if it's morphology, it could be PVC. And at times you look at this ECG. So this patient does have this ECG recorded, and when you ask the bedside nurse, you were told that patient developed some pre-syncope symptoms. He complained of dizziness. Then you become concerned of this rhythm. So they could not be artifacts. And when you closely look at these ECG, they are like very fast QRS complexes that are different from each other, they are different morphology. So it's polymorphic. So we will call it polymorphic VT. Or if you closely look at this, it seems like it's rotating its axis. So whenever a polymorphic VT is going around the axis and changes direction, we call it torsades de pointes. So torsades are very specific arrhythmia, which most of the times you found in certain conditions, and those conditions are usually digoxin toxicity or long QT syndrome. So when we look at the baseline ECG of that patient who has this polymorphic VT or torsades de pointes, you look at the QT intervals, and QT intervals were remarkably high. So in that scenario, you have to treat that patient. And for you guys, the PICU fellows, it's not necessary that you are dealing with a congenital long QT syndrome who has some genetic mutation. Many of your patients will going to have acquired long QT syndrome. That means you put that patient on multiple drugs that can prolong the QT interval. Like, as an example, you give ondansetron. At the same time, the patient is on some antibiotics like ciprofloxacin. At the same time, you use some antiemetic medications. So all of them can prolong the QT interval, and as a result, that patient can have the acquired long QT syndrome. At the same time, the prevalence of congenital long QT syndrome is not that low. It's 1 in 2,500. So it could be a possibility that some patient does have long QT syndrome, goes undiagnosed, come to you, you give some medications that really prolong the QT interval, and patient develop any kind of arrhythmia, most likely torsades de pointes. So ventricular tachyarrhythmias, which underlies the cardiac event of long QT syndrome, are the torsades de pointes, a curious type of ventricular tachycardia, which most of the time is self-limiting, but can cause sudden cardiac death, or can produce syncope, or can degenerate into ventricular fibrillation. So you need to be very careful about it. So I'm going to finish this presentation by asking a question to you guys. A 12-year-old who was admitted with a febrile neutropenia, bedside nurse rushed with a 6-lead ECG and the ECG is attached, how will you manage this patient? I will give you some time to think over it. You can pause the video, think about it, and then I'm going to give the answer. And the answer for this ECG or for this question is you have to ask the nurse what the patient is doing. If the patient is eating food, sitting on the couch, it's most likely a artifact and you have to repeat the ECG. But if the patient is collapsed or having episode of syncope, you need to start the CPR. So knowing what the patient is doing is equally important as looking at the ECG only. Here I will finish. Thank you for having me. Thank you very much. So for conclusion, pediatric arrhythmias are disorders of cardiac rhythms that can range from benign to life-threatening. We should be aware of those rhythms and prognosis is good if managed properly. Thank you very much.